I'm going to turn over now to Robert Vitillo, head of the Caritas Internationalis delegation to the UN in Geneva, special advisor on health and HIV for Caritas Internationalis, a well-known figure to many of you. Thank you, Father Bob, for your intervention. The floor is yours.
Good afternoon. I'm going to forego the slides. You can look at them on the resource website. I'd just like to summarize a few of the points that I perceive about faith-based organizations or faith communities as well. One is, and this has been mentioned several times, but that we are in the communities before the crisis and we will be there after. The international NGOs and foreign government experts who have done a great job, but after they have left. And just to give you an example of how crucial those community-based programs are, a lot has already been said by Sue and by Sheikh Abu Bakr, but I think we haven't talked enough about those community clinics. When I went to Liberia for the first time, I went to see the Minister of Health, and I knew him already from many meetings in Geneva. He welcomed me to his country and said, "Now, Monsignor, sit down. I want to tell you what I need from you before you tell me what you're going to do for me." I'm used to hearing that from bishops a lot, so I sat down very quietly and respected Mr. Minister. And he said, one, you have to get St. Joseph's Hospital reopened. We lost 9 staff there. We had to close the hospital, and I promised him that I and many others were working very hard to get it reopened. And we reopened it with the government's approval, but also in collaboration with some of the other non-faith NGOs and international NGOs as well. It's functioning well. It was used as the reference hospital for problem pregnancies and for difficult deliveries and infants who were in danger. The government hospital used the Catholic hospital as the reference hospital. It still is using it that way now. But also the minister said, right now, Monsignor, this was in September of last year, we're losing more people because of appendicitis and because of motor accidents, because nobody else is doing the surgery. Your clinics, even the small clinics, can do that surgery. Please keep them open. And we were able to keep 16 of the 17 clinics open. We need access to funding and resources, however, in accord with the burden of care that we shoulder. And I think that's a principle that hasn't been mentioned here. We've heard about lots of new schemes and new ways of doing this, and we've heard that we're too fragmented, we need to get together with others. But maybe a principle is in accord with the burden of care that we shoulder. We also treat the whole person and the whole family, and there's really not that much of a question of a silo approach, because very often we're the only provider in the area where we're serving. And I think that's also very important to remember. Maybe we need to reimagine sustainable person-centered healthcare together and not simply be told about how we need to change or that what we've done for hundreds of years is no longer sustainable. We serve without discrimination. We don't have to ask about gender identity or sexual orientation or marital status in most cases, because we serve all. Now, I know there might be some exceptions to that, but for the most part, that's the case. And especially when you're working in a crisis situation, as Ebola was, we didn't stop to ask what gender orientation people had. And our calling comes from a higher area, and I say above. I'm not sure geographically it's above, but certainly it's a higher call. I'm not saying we're better because of that, but it is important to remember that we have other values and other principles that push us on. In Latin, for the Catholics at least, we say Caritas Christi urget nos, the charity of Christ, the love of Christ, impels us to do this. We serve people as Catholics, not because they're Catholics, but because we are Catholic, and we want to serve all people because of that. Also, in relation to that higher calling, we include spiritual care in what we're doing, and I think that's very crucial and hasn't been mentioned at all during this day together. It seems like we've been here for days. There's one voice that we haven't heard at all, And that's the people who receive the services that the faith-based organizations offer. And so I wanted to bring with you the voice of Yata, a young Ebola orphan from Sierra Leone. And I want to read to you the letter parts of the letter that she sent to Father Peter Conte, the director of Caritas Freetown, who's done a magnificent job in many, many ways, but especially in paying attention to the orphans. Dear Father Peter, I hope you remember the girl you met in the center at Sema Town with her younger brother. During that time, I told you there is 8 of us and that we lose both of our parents. I was also sick with my younger brother, but the 2 of us survived, thank God. 4 of us are now back in Kenema living with our aunt, and the 2 youngest among us are now back in the village living with our grandmother. My other 2 brothers, who are in secondary school, are still in Freetown with our uncle, where they are attending school. Father, things are very hard with us. Our auntie lives with her 3 children and no husband. We are helping her to sell soap so that she can pay our school fees. But 2 times now, they have attempted to rape our younger sister, Hawa, while she was out selling. Our younger brother can still not hear clearly, and his teacher said he is not doing fine in school, as his eyes also hurt. Father, I am crying to you for help. Sometimes I am angry because I don't even know where my parents are buried, and I cannot go to speak to them about what is happening to us. Auntie is also looking like she's tired of us. She quarrels with the neighbors on small issues, and she can sometimes be very harsh with all of us. The other day, I caught her crying in her room, and that made me very sad. That's the story of Yata. Let's remember that and many, many other stories of people who need the services, and let's try to reimagine the way that we work together in accord with their needs, not what we think is right to do.
Thank you so much for bringing us that very personal tale at the end, very important. I forgot to read out the question that Monsignor Vitillo was answering, so if I read it, then you can kind of have an idea. What does the faith community uniquely bring to the emergency response, such as HIV and Ebola, and what do they need to be more effective? And that was the question to which he was responding, sorry.
I hope I answered it.
You did a great job, huh? So now I'm going to hand the floor to Christo Greyling from World Vision. The question I'll ask you is, what have you learned as faith-based organizations from your long-standing work, first in HIV and latterly in Ebola, that can be applied to future public health emergencies and initiatives? And just to give you a brief introduction, Christo is the International Director for Faith Partnerships for the Development for the World International. Thank you.
Yeah, thank you. I need to put on my glasses. Now I look like you, John. But this is actually what we need to do. That's what we're here to do. To actually look at the work that has been done, the realities of both HIV and Ebola through a new lens, at both the good, the bad, and the ugly. Not everything is great. There was fantastic things, and I celebrate all the great things that has happened. But we must also acknowledge that there are room for improvement for all of us, not only as faith-based agencies, but also as agencies all around the world who need to look in a new way on how we do our work. If I look back at HIV itself and about Ebola, then we recognize that there were messaging that was harmful, that was messaging that was not sufficiently vetted, and that in that way it kind of was not really speaking to the local customs and beliefs and practices. Just in HIV, you will all remember the initial messages were saying HIV kills. In Ebola, that was the same initial messages that came out. In HIV, the local faith communities were excellent in HIV to respond to care and to care for the people living with HIV and for orphans and vulnerable children. That was spontaneous to come. But it was difficult to speak about some of the more tough issues on holistic prevention messaging. And very often, the messaging from faith communities started off with judgment and pointing fingers and stigma. That's where we started off on. In terms of Ebola, we also realized that there were not so helpful responses initially. At the emergency meeting last July, the Liberia Council of Churches described Ebola as a divine punishment for acts of homosexuality and government corruption. I read a number of ways that faith communities, especially the churches, responded and utilized scriptures that stated, well, if my people will humble themselves and pray, then God will heal the land. So there were messaging that was not really conducive in terms of this process. But then there were also the resistance to change in terms of religious and cultural practices that were there. So we mentioned the washing of the bodies and the burial processes, but there were also very simple processes of laying on of hands in prayers, but also the basic human thing in a time when people are dying is to be saying, I want to embrace you, but now I can't. Now all of this needs that there will be targeted programming for faith leaders and faith communities. But this kind of programming needs to be faith-specific rather than general in its intention, and it needs to speak from the scriptures that speak to the heart of the Christians or the Muslims or whoever leaders that they are involved with. It needs to be full. It needs to have full and comprehensive information which bridge the secular, scientific, biomedical, and technical gap with the faith community's dimensions. It needs both these elements, both a full comprehension of the understanding and the scientific knowledge, plus then this part to be able to foster behavior change and combat resistance. We need to provide a safe space. And that's a lesson that we've learned, that faith leaders sometimes need a safe space to struggle with some of these issues, to look at their own scriptures, to be able to talk with one another about that, and to struggle with it in a safe space where they can discover, frame, and embrace their responses. And then it needs to go beyond the faith leader. It needs to expand towards the congregations and the Jama'ahs so that they will also be able to engage with this. But at the bottom of all of this, if there's no trust, there's no results. The initial Ebola response in Sierra Leone saw that initially NGOs sent in young people, sent in strangers, and that led to mistrust, denial, and inaction. But when the faith leaders, as trusted community members, became involved alongside the health staff and supporting the messages that was there for Ebola, then the preventive messages were started to embraced. This teacher, Yata Kamanda from the Bow district in Sierra Leone, she said, "We believed our imams and pastors when they told us Ebola was real. We heeded their advice about hygiene and burial practices, and it saved our lives." So, faith-inspired NGOs are uniquely placed for a few different reasons. They have the existing relationships and the trust with the local faith communities. They understand the faith-related issues. They speak the language of faith that relates to the local faith leaders and faith communities. They have existing programs to be able to catalyze faith communities for a comprehensive approach. And as a result, there will be faster uptake of messages. That's what we saw. Change in behavior, and they are able to mobilize appropriate care and protection for the most vulnerable. So what do we need? We need, in future, for future public health emergencies, to put people first. Plan and implement community engagement and social mobilization with communities, and this should include people local communities trust most. ensure message and messenger coherence. So get the message right and deliver it by trusted messengers, which include faith community, faith leaders. And then ensure that faith communities are fully part of the preparedness and the recovery programs afterwards. That includes maternal and newborn child health, child protection, and gender issues. But remember, the battle is not over.
Thank you. Thank you, Christo, for pointing out that we don't always get it right. We don't always get it right in the UN. As governments, we don't always get it right. And the honesty that the faith community, whilst it brings so much, doesn't always get it right, and we need to work harder together. I'd like now to introduce Reverend Nicta Lubaale Makiika, who's General Secretary of the Organization of African Instituted Churches. And I'd like to ask you if you have any additional points to add to the questions that we addressed to Father Bob and to Christo. The floor is yours. Thank you.
Thank you. I think much has been said, but I remember one question I was asked by the district medical office at the peak of HIV/AIDS deaths and stigma in the early 90s as a young man in ministry from a church which is not mainstream, and I was mobilizing people to respond to HIV/AIDS. And the first question, who are you? We don't know you, but you say you are part of the faith communities. I said, I'm from an independent church, but which church? That's what we need to talk about sometimes when we are responding, that even in faith communities, sometimes there's a struggle for others to fit in. We went on to build a care system that was based on partnership between the hospital, the district government hospital, the churches, mainline churches, Pentecostal churches, independent churches, and the district office. We worked with the health centers by government and faith communities. And by 1996, we had built a care system which was supporting 4,000 people living with HIV at the time when ARVs were not accessible. But that question for about 2 months kept coming on, but who are you? But we said we shall stay. And later we realized that we were brothers and sisters dealing with the same issue. So I think at community level, because I was not working at the national level, even government agencies thought that the response from faith communities has to flow from the headquarters of the faith community. I think when I talk about local responses, we need to look at that. Whether from mainline churches, from newer churches, from independent churches, from other faith communities, we need to look at the role of the imams, of the pastors, of the priests at the community level, because they are at the front line. And these are the people who bury, these are the people who care for the sick. How do we get their resourcefulness? Because many times we arrive with prescriptions of what they have to do. So the very first thing we have to learn is that even in an emergency, let us realize that whether there are no healthcare systems, someone has been caring. Someone has been playing that role. And who is that person who has been playing the role? What are the informal institutions? Interestingly, when you look at even the most recent data from UNICEF, Kenya, a country which seems to be progressing, it's only 40% of the mothers who give birth at the attention of a skilled person. So who cares for, who does the 60%? And at what risk are they? Korogocho, a slum near Nairobi, 60% of the mothers still give birth at the hands of traditional birth attendants. Korogocho is not 15 kilometers from Nairobi Hospital or Kenyatta National Hospital, but yet it's so far away. Yet the traditional birth attendant is near. In a survey that was carried out, they said they care for us better. They never go on strike. They never close their doors, and they don't insult us. So that means the values of the traditional birth attendant, this grandmother, are needed in the training of the midwife. That is the reality. She has a role to play without an emergency. Then the other thing we need to recognize at community level is that there are big emergencies which have never become emergencies. Why is it so that pastors are burying people? From my Christian tradition, we need to transform theology. We say, Lord, we are bringing back your servant whom you've called back home. And really, this is a mother who has died giving birth. When you compare Sweden, 7 maybe in 100,000, and maybe Burundi, over 700. How comes that God is in the business of calling African mothers Ale? You know, those are the things we ourselves are confronting and we have to deal with. But at the same time, we have to respect those who are at the local level. The biggest question is, what are the informal systems that are filling the gaps of the healthcare systems, the formal healthcare systems that are absent? Can we look at that before the crisis hit so that we know how to bring these people so that they can be stakeholders? Because we said there are no healthcare systems, yet there are some informal healthcare systems, and this, what is informal to us is so formal to them, because that is what is accessible to them. We are so informal to them, who arrive at the time of the crisis. We need to recognize that. And when we work on that, I think we shall expand our understanding of healthcare systems, including the pastor, including the women fellowship, including the grandmother, including the Muslim women's fellowship, because that's where their issues are discussed. So in working at community levels, we are understanding over a period of time and with engagement with HIV/AIDS that there are many carers. The healthcare systems are beyond what we understand. And those people who are not part, and the institutions which are not part of the formal healthcare systems are hit most at the time of crisis like Ebola, because they go on to do what they know what to do, even when they are at risk. And finally, I would like to say that we need to engage the local faith communities in turning around policy. Because for long, they've celebrated self-provisioning. For long, they've celebrated what hurts them. For long, they've celebrated what government is supposed to do as their role. I think moving towards a framework of social accountability, even as we move in the SDGs, will be key. Working with the local faith communities, whom Sheikh talks about, who bury, who care, who are at risk. They are still far from what we are doing, yet it is possible for us to work in partnership. Let's expand that partnership from the national to the local.
Thank you so much. Thank you, Nicta, for reminding us of the importance of those local partnerships. I'd like now to move on to Frank Dimmock, who's from the World Mission Catalyst, addressing the root causes of global poverty through the Presbyterian Church in the US. And he's going to talk a little bit about some of his work with the Christian health associations, particularly in Liberia. The floor is yours, Frank. Thank you.
Thank you, Sally. Good afternoon. Much of my work has been in the continent of Africa. Let's see if you've seen this map a few times today already. And my experience has been mostly with Christian health associations or networks of Christian health work in many of these countries. Beginning at the time of independence, about 50 or 55 years ago in many of these countries, governments wanted to work with an umbrella organization or an association of Christian health providers rather than with each one individually. Now there are about 16 countries in Africa with active health associations, and there are 5 more with smaller or new networks and a few others with some networking activities. And in these countries, faith providers are contributing about 5 to 50% of the health services, and often in rural, hard-to-reach areas. I'm missing a slide. My slide on Liberia is the next slide. And looking at Liberia as an example of Christian health networks, there is the Christian Health Network or Christian Health Association of Liberia, which has 58 health facilities, 5 hospitals, a number of health centers and clinics, in 12 out of the 15 counties of Liberia, and about 2,200 trained health workers, about 24% of the health workforce in that country. They responded rather quickly to the Ebola outbreak in Liberia, and were able to do social mobilization and behavior change and communication. They provided financial assistance to Ebola survivors. They distributed 17 containers of assorted PPE and medical equipment. They provided risk allowance to some of the health workers, and they did health facility strengthening, installing hand washing facilities and so forth in a number of health facilities. So they were instrumental at communities and working with the network to address the Ebola outbreak in Liberia. And this slide presents some of the value added, if you will, of Christian healthcare providers in both the community and informal settings. They are part of the community. They have been and will continue to be an excellent point of contact. Often they'll provide care in the most remote areas where some of the highly vulnerable populations are found. They're engaged in formal training and community-level training and supervision of health workers. They have pioneered many prevention and treatment methods, but they also face a number of challenges, some of which you've heard today already. Building the capacity at secretariat level, the memorandum of understanding between these associations and their governments, experimenting with service level agreements, a lot of this I was involved in, responding to health reforms, policies by the government, and participating actually in that planning and policy setting has been a challenge for many of these associations. These national Christian health associations are also networked continentally under what's called ACHAP, which is the Africa Christian Health Associations Platform. And this network was established in 2007 at a meeting of the Christian Health Associations in Tanzania. And it's enabled the sharing of strategies and programs and the exchange of resources between countries, exchange visits, and the formation of technical working groups to look at areas such as human resources. The key in partnership is the networking within the faith community and across the health sector. And by resourcing the faith networks, these Christian health associations, as an example, at national and international level, communicating and planning together as partners, there can be a synergy and a collective impact on the health challenges. They're also engaged in producing regular publications, bulletins, featuring the work of various Christian health associations on the continent, and human resource publication, human resources for health publication that are distributed by ACHAP, by the Continental Platform. These are some of the logos of the members, the various countries that are members of the Continental Platform. And these are some of the development partners. There are more, but we must recognize and reinforce the partnerships between the international agencies, the bilateral assistance, universities, and the faith-based organizations, and their connection with ministries of health in their respective countries. As Chris Simonga mentioned this morning, and Christoph mentioned a moment ago, building partnerships requires trust, partnerships of all types. And trust is built around open dialogue and evidence, as Matthew Frost suggests this morning as well. So we must balance the science of health together with the worldview of the local providers, the indigenous health providers that are so critical in our partnerships. Thank you.
Thank you. Thank you. Thanks. Thank you, Frank, for bringing together the local networks of the faith community with then those service providers through the hospital and community networks. Thank you. I'd like now to invite Christoph Benn. Christoph doesn't need much introduction to many of you as the Director for External Relations to the Global Fund for AIDS, Tuberculosis and Malaria. And Christoph's going to respond to the question, what have been the strengths and challenges of the faith community as implementing partners of Global Fund grants? And what can be done to strengthen partnerships with FBOs in future public health initiatives? Thank you. The floor is yours.
Thank you, Sally, and that sounds like very big questions at the end of a long day. So I can actually reassure you I won't answer all those questions because that would take far too long. I think I'd just offer 3 brief reflections and comments, if you like. We've been reflecting here on what we've learned from the response both to HIV and to Ebola, and there are actually quite a few similarities, if you like. And I know that many of you here in the room, and certainly many here on the panel, have been quite involved in the early response also to HIV, particularly on the African continent, also at a time when there was no treatment, there was no kind of biomedical solution. And like with the Ebola response, the solution was with the communities, because you're really talking about, addressing behavior that put people at risk, educating, communities about this new virus that nobody had heard about, and how you could protect yourself. So I think there's a lot of similarity, from the early HIV response and now the response to Ebola. The international community has been rightly criticized for responding very slowly and insufficiently. And I think the criticism is justified. But when I heard all the presentations here, I don't think you can say that the communities in Guinea, Sierra Leone, and Liberia have responding slowly. It was much, much faster than what we experienced in the 80s, for example, in the response to HIV. And I don't think I can present evidence for that, but there could be an argument to say that maybe also it was faster because of the experience already with HIV, that some communities could build on that response. And therefore, fortunately, the communities were much faster in their response, which cannot necessarily be said about the international organizations. Very briefly, as you asked the question, for an international organization like the Global Fund, what has been our experience also with the faith community in this situation? Fortunately, we already had a number of faith-based partners in these 3 countries. Actually, in both Sierra Leone and Guinea, Catholic Relief Service has been our principal recipient on the malaria programs, and we've been working with a number of other faith-based organizations as sub-recipients in those countries. So, what could we do? Basically, we could just allow the maximum flexibility to say, use the resources that you already have from our program. It doesn't matter whether it's about HIV, whether it's TB, malaria, and use that for what you need now in this emergency situation. And some used it to kind of use the resources to buy, disinfectants and gloves and protective gowns and so on, which was much more important than what you would need maybe for the malaria programs. Some used it quite successfully to train a lot of the community health workers, and we did support that. I mentioned this morning our partnership with the United Methodist Church, and we have joint programs for malaria control in both Sierra Leone and Liberia. And Reverend Gary told me also today how they produced information material, originally for malaria, but then for Ebola in 20 local languages. Because we often think, not everybody speaks French or English, but you need to communicate in the languages that the people understand. So it was a faith community, and we're a proud partner of that could use that to communicate in the language that was required here so that people would understand that. So in a very kind of limited way, I think we've been able to contribute. And I really want to say, the heroic work has been done at the community level and often through the faith communities. The role that international organizations in Geneva could play was very, very limited. And you can say too little, too late. But a lot of heroic work has happened at the community level. And I would really like to applaud, all the communities that have been engaged in that. And the final one is about the future. What are the lessons learned, and what can we do to prevent a similar crisis? I think, Sue, you mentioned that the WCC is working on firewalling against, future epidemics, and how can we invest now in communities to prevent, similar disasters, and to be better prepared in the future. I think that's the challenge now. I've heard over the whole year there has been so many international meetings at the highest political level talking about post-Ebola response, and usually it is about strengthening health systems and building resilient health systems. And that is certainly very important. But probably even more important than that is building resilient community systems. And it would be now the time to invest in the community systems, as much as, looking at hospitals and infrastructure and, disease control centers and all of that, as the communities were the kind of front line in the fight against Ebola, they will also be the front line in any future epidemic and disaster. And I think it would be, very important for all the international community, including the Global Fund, to consider that now, how we can invest much more in community systems that will then, help to build resilient communities, if you like, which might be more important than resilient health systems. So just a couple of thoughts, but thanks a lot. And thanks, I think, particularly for all the people who did all the important work at the community level. Thank you so much.
Thank you, Christoph. Again, just to recognize the important work of those in the communities themselves, many of whom gave their lives, the ultimate sacrifice to serve those in their own communities. So just thank you very much for that reminder. We're running very late, but it's good that we do have some time at the table groups. And we gave the table group facilitators the same questions as we'd given to the panel. But what I would suggest is, given the limitation of time, that you just take one of those questions at your table, that you choose one, particularly looking at what the faith community perhaps has got to bring to emergency responses moving forward, and what we need to move forward with that, and how we can partner more effectively with the international community to do that effectively. So look at the questions with your facilitators at the groups. We'll come back and report back one recommendation from each group. And just to point out that there will be 3 of us going from this meeting tomorrow to a meeting at the UN, as Christoph said, one of the high-level meetings on planning the way forward. And there'll also be a second meeting in Cape Town next week, planning the way forward. Give us some strong recommendations that we can take from this meeting as to how the faith communities can be a critical actor in preparing for future epidemics. So if you'd like to move to your table groups, I'd hand over now to the facilitators. Thank you.
Thanks, Ellen.
First of all, want to just take a moment to thank the panel. We're not going to call everyone else back up again, but please thank the panel. A huge amount of work and a huge amount of experience. And I don't want to take a lot of time because everyone's tired, but I wanted to just take some of the things that we've heard right now and take it, if you like, just up a level. We've lived through HIV, and we've learned all these things. We've got curricula in theological training colleges on development and HIV. We've lived through HIV, and we've looked at stigma and how communities are able to address stigma and discrimination. We've looked at how the role of the faith-based health service providers can be critical in scaling up service delivery, both through facilities and through communities. And yet we come to Ebola, and we have exactly the same set of issues. And we don't think to draw on that experience and that wealth of resource. So I'd like to challenge us to look at some of the C's. We had Tim come to us before with all the S's, but I've got the C's. Community responses are not the same as community mobilization. Community responses are those responses we've heard about just now, how the community responds at that immediate crisis. And in order to do that, they draw on some of that community resilience that they've got as part of those networks. They have community leaders who have influence and can help us to shape our messages. So that when we want to do community mobilization, we don't just throw messages at people, but we work with those leaders who are experts in their own cultural and anthropological practices. And they can help us to shape those messages and mobilize their own community in ways that work. They draw on the community systems that are there to take up that load-bearing infrastructure in times of crisis, than the women's networks and the youth networks and the elders in the community. But also those infrastructures and those systems of health service delivery, the hospitals, the clinics, the community health workers and the outreach workers. And so I think one of the things that this whole epidemic of HIV and then Ebola has taught us, that the simple issue of engaging the community or mobilizing the community or doing some community system strengthening is too piecemeal. We need to look much more carefully at what we need in terms of a full community response, and in terms of our health systems strengthening response, in terms of our preparedness and resilience work. What is the matching set of skills, set of people, set of disciplines and resources that we're needing in order to make a difference, not only in HIV, not only in Ebola, but in other crises as they move forward. So I think what I've heard from this meeting, what I've learned from all of the work we've done on HIV and the work of the faith community on Ebola, is that we've got to be much more intentional about documenting those different elements of community and how we would build those disciplines as an interdisciplinary team to work together to address future crises. So I hope that's a helpful kind of synopsis of what you've been trying to say, what we've all been hearing. And I want to thank you very much for your attention today and for your long suffering in what was a very long but a very rich day. Thank you, and hand back to Jim.